Members, this is the appointed time and we have a quorum, so I call this meeting to order. Item 1. Information paper issued since the last meeting. The Secretariat has issued 2 information papers since the last meeting. You'll find details in the agenda. Item 2. Schedule of meetings for the remainder of the 2025 session. In accordance with the rules of procedure, the President of the Legislative Council has laid down the schedule of meetings for the second half of this year, and you will find tabled the schedule. I propose the regular meeting dates for July to October of 2025 for this panel as 11th of July, 12th of September, and 10th of October. 10:45 a.m. Members, do we agree? Right, the Secretariat will issue a notice to inform members of the agreed dates and time. Items for discussion at the next meeting. The next regular meeting will take place on the 9th of May 2025 at 10:45 a.m. 2 items were discussed: update on the elderly health care voucher Greater Bay Area pilot scheme, as well as the current arrangements and next steps for the storage period of gametes and embryos. Any questions? If not, then these will be the items to be discussed at the next meeting. We now move on to the next item, latest progress on establishing the Institute for Medical Advancement and Clinical Excellence. Let's invite the administration to come in. Members, if you want to ask questions, please press the request to speak button. Good morning. Let me welcome the team from the administration. We're joined by Professor Lo Chung Mao, Secretary for Health, Professor Gilberto Leung, Convener of the Institute for Medical Advancement and Clinical Excellence, Mr. Sam Hui, Deputy Secretary for Health, and Mr. Ronald Chang, Principal Assistant Secretary for Health. Let's invite the administration to walk us through the paper, please. Chairman, members, I'd like to brief members on the latest progress on establishing the Institute for Medical Advancement and Clinical Excellence. At the moment, there is neither an official system in setting common clinical standards and guidelines between public and private healthcare services, nor a set of uniform standards. Patients may need to rely on the individual judgment of doctors. That accounts for the potential variance in the standard of care. With an aging population in Hong Kong and increased prevalence in chronic diseases, there is a need to enhance consensus in the healthcare sector to benefit patients. In light of the above, the Policy Address 2024 has proposed that the government would establish a professional platform for developing evidence-based clinical protocols and explore the service quality and efficiency standards for public and private sectors. Last year, I invited 7 founding members to establish the IMACE. They include the Hong Kong Academy of Medicine, the Department of Health, the Hospital Authority, Primary Healthcare Commission, the Faculty of Medicine of the Chinese University of Hong Kong, the Li Ka-shing Faculty of Medicine of the University of Hong Kong, and the Hong Kong Private Hospitals Association. All the invited institutions responded positively on their participation. This forms a professional evidence-based platform for data to be collected and for in-depth research to be conducted to drive at clinical options. The IMACE will set up a professional-led and evidence-based platform, and they will also deliberate on clinical practices and evaluate the efficacy of different medical options before drawing standards. This also facilitates the exchange among professionals and discuss how the latest technologies can be applied in a daily practice to promote Hong Kong into an international health and medical innovation hub. We will actively encourage the healthcare personnel to apply the protocols where appropriate, but they will still need to rely on their professional clinical judgments in giving the best medical options for individual patients. To uphold professional autonomy for the healthcare sector, the Health Bureau will fund the operation of the center, but will not involve in its governance. On the Bureau's invitation, the Hong Kong Academy of Medicine has nominated the past president, Professor Gilberto Leung, to serve as the first convener of the council and provide the center with initial operation. IMACE will be set up in May 2025, and I encourage further discussion and collaboration to help Hong Kong scale new heights. I will now give the floor to Professor Gilberto Leung. Thank you, Chair. Thank you, Professor Low. First of all, I thank the government for the support of the establishment of this professional platform. I also thank the Hong Kong AM for nominating me as the convener of the center. The IMACE has two major tasks. The first is to draw up clinical standards and to give advice on healthcare services. The second is to enhance the public's understanding. Now, as far as the first task is concerned, that is in relation to drawing up clinical standards, this is a necessary task because in light of medical advancements, there are more drugs and medical devices available as medical options for physicians. But there are varying degree of uncertainties in relation to these devices and drugs. Some may have known efficacy and advantage over traditional medicine, some may not. And in light of the rapid development, it is quite difficult to have a full grasp of the relevant knowledge and data, and this may result in potential variance in standards of care. For acute stroke, for example, in the past, the only available treatment option is oral medication, and this is not desirable. This leads to some mortalities. But in recent years, we have developed new options such as non-invasive surgical options to work on the blood vessels. But this may have varying results depending on the patient's conditions as well as the time frame for treatment. So through this local platform, the healthcare colleagues can all study the relevant data and evidence together before drawing up the clinical standards and guidelines. These will help doctors make the best choices. More importantly, if the patient is residing in a hospital without the above treatment option available, the doctor in charge will be able to make necessary referrals. In terms of the patient's conditions and overall healthcare structure, this platform will provide a very positive effect to the development. And this platform will not mandate the doctor's treatment options. After all, we still rely on the doctor's professional judgment. The platform, however, will serve as an important reference for doctors to be equipped with the latest knowledge and technologies. The second task for the center is to promote public education. This is also essential because patients may know about these new treatment options, but they are not equipped with the professional knowledge as a doctor. So there is this problem of information asymmetry. The IMACE will enhance the public's understanding of the fundamental knowledge. We're not asking patients to be doctors, but we'd like patients to be able to enhance communication with doctors so as to help them make informed choices. In fact, we have started preparations such as discussing the governance structures of this excellent center. We will draw up standards and guidelines when the center starts operation in May this year. According to overseas experience, it takes 12 to 18 months or even longer to draw up clinical standards and guidelines afresh. So at the initial operation of the center, we will have regard to the existing standards and protocols adopted by the medical schools in Hong Kong. At the moment, these standards only apply to certain fields of the healthcare sector. We will review and evaluate the situation and adapt such standards and guidelines so that they can apply across the board in both healthcare and public and private healthcare sectors in Hong Kong. And that's all from me. Right. If there's nothing to supplement, I'll open the floor for members to ask questions. 3 members would like to speak, Mr. Chan Kin Po and Ms. Rebecca Chan and myself. I'll give each member 5 minutes questions and answer. We'll start with Mr. Chan Kin Po. Thank you. I support the establishment of the Institute for Medical Advancement and Clinical Excellence. As the paper suggests, there is a lack of clinical standards and guidelines that can be applied across the board. And according to the paper, setting up this platform could enhance efficacy and cost effectiveness. And of course, it is a good thing to enhance the quality of care. We didn't have the standards in the past. As mentioned by Professor Gilberto Leung, the standards could be drawn up in 12 or 18 months' time. I hope that we can speed things up. My next question is about the standards and guidelines. We should make sure that they include specific details. They should not be too broad or too vague, or they will lose their meaning. You should make sure that the standards and guidelines are adopted widely. And what will happen if healthcare professionals fail to follow the standards and guidelines on a prolonged basis? Is there anything to ensure compliance? Secretary, I'll give the floor to Professor Leung to take this question. About the time frame of 12 to 18 months, this is in fact a reference from overseas experience. I believe that where the circumstances permit, we will be able to speed things up. This platform does not have the oversight function. It's not a regulator. But still, the standards and guidelines to be promulgated will be quite representative. And this will be cited by the expert witness in criminal or civil proceedings. Though these experts will rely on evidence as well as the standards and guidelines in giving their opinion, and it's very likely that they will quote from the standards and guidelines. So for clinical practices departing from the standards and guidelines, they must be justified with very cogent clinical evidence, because they will be required to explain why they're departing from the standards.
Chair, if I may supplement, when we draw up the guidelines, well, we will be evidence-based at various levels. Well, in some cases, we have level 1 evidence. In other words, we have got a lot of objective data to say that a certain option, a certain treatment is the golden standard. Then it will be up to a doctor not complying with the standard to justify it. And then in other cases, we may have guidelines, but then the evidence required for the evidence-based system may be of a level 2, 3, 4, or even 5. In other words, the guidelines are based on experts' opinions only. In other words, in such cases, will not be that sort of tight in a sense. When we drop the guidelines, in some cases, we may not hold them very seriously or vigorously, but in other cases, doctors who are non-complying will face serious consequences. Chair, if I may follow up, please. Well, for us in the insurance sector, we are in a very difficult situation. We're faced with a lot of frauds, and then the premiums will be going up. If we do not do anything about it, many people will not be able to afford their premium rates, and it will be dealing a fatal blow to us. So I want to know whether such guidelines would apply in our sector as well. Well, sometimes some options, some treatments or procedures are unnecessary or inappropriate. Today, we don't have a standard to draw reference from. So I want to know whether we can sort of decide on whether we pay for the claims or not. Secretary, well, the guidelines are for our sector's reference. It will be regarded as a standard for our sector. In overseas countries, different organizations have issued such guidelines. For us, our disease types and our population profile would be different from theirs. Mr. Chen talked about fraud. I think it isn't just a matter for the guidelines. I'm sure in the future our guidelines will be of some reference value. But then for fraud, it is a matter of a criminal act. It is not a matter of professional professionalism or professional ethics. Ms. Chen. Well, we want to have the dual track system for the public and the private sectors, but then fees and charges vary significantly, and therefore we have the imbalance. The government has done quite a lot, say for example, asking the private sector to come up with transparency in the fees and charges. Now I want to talk about the following. For the clinical guidelines, etc., the purpose is to assist with public education so that the public may know about the medical options they may face. But then it will be something very professional and requires expertise to understand. So would you explain better the purpose to be served by the guidelines when it comes to public education? The Consumer Council earlier on talked about the complexity of the fees and charges imposed by the private sector. Even though the fees and charges have been announced, it will be difficult for the public to comprehend. So for you to publish the guidelines as well as the benchmarks, how are you going to convert them into something that can be easily understood by the public? And then for the private hospitals, sometimes we may have administrative arrangements guiding the choices. So how can you make sure that even private hospitals would follow your guidelines, etc.? Well, for the guidelines, I have to emphasize that when it will be good for the public to have access to the guidelines while we allow them to enrich their information. I have to emphasize that for serious conditions, I hope the members of the public would understand that they must consult a doctor before they can identify the best medical option. By providing information to the public, it facilitates communication with the doctors so that they can better understand what the doctors say. But then what is important is for the doctors to discuss the case with the public instead of the public trying to choose an option for themselves. Now, for private hospital fee charging policies, Well, of course, on an invoice, you have many items. Pricing will not be covered by the work of the institute. We'll be talking about examinations, treatments, among the various options that we explore. We won't talk about fees and charges. For private sector fees and charges, well, in fact, we have another sort of program. We'll be talking about the transparency of the fees and charges. You also talked about the administrative principles of individual private hospitals. Well, we'll be focusing on the medical options. As to the administrative choices, well, I don't think the institute is going to impose any mandatory requirements. However, if the private hospitals are having such administrative arrangements that would affect the quality of the clinical procedures, then the guidelines or the standards proposed by the institute can be counted upon to deal with such unreasonable administrative arrangements. Thank you. Any follow-up? No, thanks. Next, Mr. Peter Shiu. Thank you, Chair. Well, the Bureau is saying that by having the institute, then the medical procedures and options can benefit from the new guidelines. I'm sure this is something good. Well, for the founding members, other than the government departments, we have university members, and we have also got other professional bodies. So I'm sure the membership is appropriate. My question is, for you to set up the institute, you'll be calling meetings and you'll be carrying out studies. So I want to know who will fund the operations of the institute. Professor Low, there are 7 founding members establishing the institute. Indeed, they need administrative costs. This is because they need to have dedicated executive staff members working full-time as well as part-time, and then they need to gather information to draw up the guidelines so that at the end of the day, there will be a set of guidelines common for public and private sectors. So they will need money to run the program. Now, the Academy of Medicine is the executive agent, and they have assessed the cost needed. With an increase in the number of guidelines, I'm sure manpower needed will also increase. But for the time being, we do have a rough idea of what is needed financially. I would like to defer to my colleague to answer this question. Yes, for the recurrent expenditure for the operation of the Hong Kong AM, it comes from the expenditure it comes from the funding of our bureau. But then we'll only be providing the financial resources. As the Secretary has already said, the actual operation of the institute will be evidence-based. So we will set aside the money for the Hong Kong AM to support the work of the institute. The day-to-day operation, etc., will not have any thing to do with us. We don't play a role in that sense. So for the initial phase, on an annual basis, we will be setting aside $19 million. We believe that this is adequate for the institute to recruit a professional team. Initially speaking, they would need 10 to 11 professionals to help them. And then the institute will also have to spend on non-manpower related items. Say, for example, we need to enhance the public understanding about the guidelines, standards, etc. So if we want to popularize the knowledge, we need to carry out certain publicity work. So we're going to spend money on manpower as well as the operation of the institute. There will also be non-recurrent expenditure as well. So will be providing the resources from the money of the Bureau. Well, the Institute will look at the screening, the management, the treatment options of different diseases and conditions so as to screen the efficacy and efficiency of drugs, devices, etc. But then before the Institute is to be set up, I want to know who is doing this. Well, before the establishment of the Institute, all doctors in Hong Kong will professionally identify the evidence needed to support their decisions. Well, they have already got the information when they were studying, when they were trained, and they have to carry out continuous education. They might have graduated 10 years ago, but they're supposed to have been updating themselves since graduation. But then there is variation. Some may be working at a faster pace, others not so. So we hope that we can set up the guidelines. And in fact, in the public sector, we hope to do so. And individual organizations like the Academy of Medicine or different colleges of specialties might have their own guidelines. But generally speaking, we don't have a platform to have guidelines or standards applicable to everybody in Hong Kong. You may say that they have CDC, MIH in the UK, but then such guidelines may not apply, may not be applicable to the cases in Hong Kong. We are different. So today, we hope we can have the Institute, and then we can put together the guidelines from all over the world, and then adopting an evidence-based approach, we can come up with a set of common guidelines. As Professor Leung has already said, we want to treat the stroke patients. In the past, we used to think that the harm would have already been done when a patient undergoes a stroke, and we would only be aiming at reducing the secondary harm. There is growing evidence that, in fact, we can have a more advanced option so as to reduce the harm done, the impairment done, and sometimes we may even be able to revert the impairment which was previously thought to be permanent. So we need to look at our own healthcare system, and then we develop our own guidelines. Can I have a follow-up? Second round, please. Thank you. Next, Mr. Chen Wing Kwong. Thank you, Chair. Well, in relation to the establishment of the Institute, I have the following to say. We have been told about the work to be carried out by the Institute upon establishment. But what are the benefits for the public? I'm not too sure. So can the Bureau tell us more as to the social benefits to be attained upon the establishment of the Institute? And I really want to know how members of the public are going to benefit from the establishment. And then in paragraph 3, it is said that the establishment of the Institute can slow down the increase of the medical costs. Can you promise that the costs can be maintained at the same level for a number of years? Can you make a commitment? And then for the Institute, please tell us how much money is needed and what about the manpower to be required by the Secretariat. I would also like to ask for your confirmation, that is whether the traditional Chinese medicine sector will also be invited to join the work of the Institute. If not, why not?
Secretary. The Institute for Medical Advancement and Clinical Excellence will serve a very important purpose, especially when a member of the public falls ill At the moment, when a patient visits a doctor, they may receive one medical option advice and then another if he goes to another doctor. So there may be a variance in the standard of care. That's because we do not have a platform to provide common standards. With the promulgation of common clinical standards and guidelines, we can achieve higher standards in relation to treatment options. In our medical profession, doctors exercise autonomy, and according to their professional judgment, they provide advice and treatment options. And there may be variations as a result. We want to narrow the gap, so to speak. But there are different tiers of evidence available for different clinical options. Now, as for manpower, and also according to the establishment, with an expenditure of 19 million, we will set up an establishment of about 10 to 11. Resources will come from within the Health Bureau. The Hong Kong AM will then make use of the resources to hire their own professionals to undertake this task. The member also asked about Chinese medicine. For the institution, the standards will first be drawn up by professionals in the Western medicine discipline. In our view, it is not appropriate to allow Chinese medical doctors to participate in the establishment of the institute at this stage. We understand that the Chinese medicine profession also comes under another regulatory regime. So with the establishment of the institute in the future, some working groups may be set up and other professionals may be invited to join the discussion. For example, if IMAs would like to look into matters relating to Chinese medicine and they would like to invite the Chinese medical practitioners to help set up and draw up standards, then we will invite the Chinese medicine sector to participate in the deliberation process. I'm the last one to speak on this item. I support the establishment of the Institute for Medical Advancement and Clinical Excellence. We take a three-pronged approach with promotion of primary health care, setting of standards, and reform. We will raise the standards of care in Hong Kong, so I strongly support the platform. When it comes to a complaint against a doctor, the Medical Council of Hong Kong refers to standards and guidelines, and at the moment, they consider standards and guidelines in different jurisdictions as well as the evidence. But if we're able to draw up our own clinical standards and guidelines, and I'm sure that they will be carefully considered. Now my question is this. The healthcare profession comprises not only doctors but other allied health professionals. Is it possible for them to follow guidelines and standards elsewhere? And apart from the common clinical standards and guidelines, we have different organizations promulgating their own standards and guidelines for different fields in the profession. So how do they stand? Thank you, Chair. A doctor should always have regard to clinical evidence when considering treatment options, and they should also have regard to clinical standards and guidelines, including local ones. For this exercise, we'll definitely have regard to the ones drawn up locally. We will have regard to the demographics, the patients, conditions, typical illnesses, as well as overseas standards and guidelines. The standards and guidelines will be discussed and evaluated by the 7 major institutions in the healthcare sector in Hong Kong. So definitely, the common standards and guidelines will carry a heavier weighting, and there must be strong justifications for a doctor not to adopt the clinical treatment option as recommended in the standards and guidelines. Perhaps there may be special circumstances in relation to the patient's clinical condition that the doctor would decide to follow the standards and guidelines in another jurisdiction instead, and that will require the doctor to carefully consider the information. The platform and provides important reference, but after all, the doctor will be the one making the clinical decision. And we'll also have regard to the relevant standards and guidelines, including some internal guidelines within the hospital authority or guidelines promulgated by medical associations. The platform will then decide on the most appropriate standards to be adopted for the sector as a whole. I have another question. We are going to amend the Supplementary Medical Professionals Ordinance. The bill has in fact been tabled into the Council. The bill sets out some codes of practice that the supplementary medical professionals should observe, and the codes of practice are drawn up by the HADH Primary Healthcare Commission as well as the Chinese Medicine Commission. So it seems to have a very different design from the one we see for the Institute. Will you consider adopting a common approach as well? As I explained, doctors will consider the clinical evidence as well as the standards and guidelines in providing treatment. Some medical organizations also have their own standards and guidelines, and they will form an important reference for the IMAs in drawing up the common clinical standards guidelines. But these two are not mutually exclusive. IMAs will have regard to the overall situation in Hong Kong. For the internal standards and guidelines, the organizations will have regard to, say, their administrative arrangements and manpower deployments. So these two sets are backed by different considerations. Second round, Mr. Peter Shiu. Chairman, I'd like to follow up on the previous question. Now, after drawing up clinical standards and guidelines by the Institute, will there be any consequence if the doctors do not follow the standards and guidelines? Now, it's not legally binding, so it's not a question of whether there may be consequences to the professional status of the doctor, but the standards and guidelines form part of the evidence. So for a clinician, any decision made should be based on evidence. They are bound by the professional conduct. They must come up with justifications in deciding not to follow the standards and guidelines. So if an incident arises, and if there is evidence to show that the doctor has departed from the clinical standards, then it's for the doctor to explain why there is a departure from the clinical standards. But as I explained, mere departing from the clinical standards does not mean that there is professional misconduct involved. The doctor will have regard to the patient's condition, the other circumstances, and the clinical setting as a whole before making this professional judgment, which may not tally with the common standards and guidelines. Thank you, Chair. Another question. You mentioned different standards and guidelines for different disciplines, and then we're spending $19 million to draw up a common set of standards and guidelines which doctors may choose not to follow. It's just for reference. So what's the real purpose of setting common standards and guidelines? Because different disciplines are already observing different guidelines and standards elsewhere. What's the main purpose of this common standards? The common standards and guidelines seek to enhance the quality of care, to reassure patients. The existing standards may not be very different from the upcoming set. We have standards and guidelines already promulgated by the HA or other professional institutions. Basically, these standards are drawn up on the basis of evidence that exists in other overseas jurisdictions. As I mentioned just now, the Institute will collect data. Now, in the public sector, there are different sets of standards and guidelines, but there may not be as many standards guidelines in the private sector. So there is a need to draw up common standards. I quoted the example of a stroke case or colorectal cancer screening. Around the world, there are standards. And likewise, for local medical institutions, there are standards. We want to draw up a set of common standards applicable to both public and private healthcare sectors. For example, what's the interval for colorectal cancer screening? What if a polyp is found? How different will the interval be for this particular patient, for example? This will provide standard protocol for patients in different conditions in choosing different treatment options. This is to reassure patients after all. Well, but Chairman, I know that there are different treatment options. You can even resort to the Chinese medical doctor, and I believe that members of the public in Hong Kong are aware of the different clinical pathways. So you're spending so much money on drawing up the common standards and guidelines. How long will it take, do you think? Secretary. Now, Mr. Shiu has made a very good point. You talked about the different treatment options, different conditions of patients. There are so many variables. That means the Institute cannot draw up the standards right away. It will take 12 to 18 months to consider everything I mentioned with sustained efforts. This is a huge workload for the Institute. In the initial stage of operation, the Institute will focus on standards and guidelines that will have a greater bearing on healthcare in general, that can be formulated easier. To answer what Professor Chan Wing-Kong said, whether there are indicators, I'm afraid we can't lay down indicators. We can't tell you, say, within a certain time frame how many sets of standards may be completed. We will not impose any hard indicators on expenditure. But from our professional perspective, we do need a set of common standards and guidelines to help healthcare professionals form objective, clinical-based judgment. This will help us provide a higher standard of care when we provide treatment to patients. Of course, higher standard is good, but from what I've heard, I am still not sure when exactly all these standards and guidelines will be completed. You may be taking your time in drawing up standards, and there are no indicators available for us to have a value for money audit. So do pay attention to cost effectiveness, please. Right, so much for this item. We now move on to the next item, that is on public healthcare fees and charges reform. Let's invite the administration to come in.
Members who would like to speak, please press the request to speak button. We have Professor Low, Secretary for Health. We have Dr. Tony Ko, Chief Executive, Hospital Authority. Mr. Sam Hui, Deputy Secretary for Health. Dr. Simon Tang, Director, Cluster Services, Hospital Authority, as well as Ms. Priscilla Poon, Chief Manager, Allied Health Hospital Authority. Welcome, ladies and gentlemen. I'll give the floor to the Bureau to walk us through the paper. The order of members who will speak. 6 members have pressed their buttons. Jovi Chen, Chen Ming Kwong, Lam So Wai, Kingsley Wong, Yang Ming Kit, as well as Rebecca Chen. Secretary, please. Chairman, on the 25th of March, the administration published the ideas on public health care fees and charges reform. We have got 5 major principles. Commitment will not be lessened, co-payment, enhancement and reduction, high subsidization, and gradual and orderly progress. We would like to be precise in our subsidization. Well, we have got 3 major areas to be covered. We would like to reform the subsidization structure. We want to reduce wastage and misuse. We want to enhance healthcare protection. We want to enhance the universal safety net, and we hope to make our system sustainable. For 2 weeks, we have been explaining the proposals, and I think everybody has got a better understanding of our proposals. Today, we would like to talk more about the enhancement of our safety net so that the public can understand that we do so for the benefit of our public. Well, there are 3 ways to enhance our safety net. We would like to help the poor. We want to help those who are critically ill. There will be an annual cap of $10,000. We want to assist the critically ill because we would be expediting the introduction of new drugs and devices. First of all, we are going to support the poor. We are going to enhance the medical fee waiver system. Today, 600,000 people are receiving fee waivers. That is 270,000 CSSA recipients, 330,000 who are age 75 who benefit from who are receiving the OH allowance, as well as those who are residing at the residential homes. And we are going to have the system to make sure that those who are eligible will have full or partial waivers. And in fact, as a result of our enhancement, we are going to increase the number of recipients or the beneficiaries 3 times, from 0.3 million to 1.4 million. And in fact, instead of just cover, and we are going to relax the income limits. And in fact, instead of 75%, it will be 100%. And then for the MMDHI, we are also going to relax them. And in fact, for the asset limit, it will be relaxed so that it's aligned with that for the public rental housing application. And in fact, we have also got relaxation in relation to the asset limit for non-drug related items. Well, we would like to cite certain examples to illustrate the points. In fact, we referred to them at our press conference on the 25th of March. I hope you will still recall that. Well, this is for the first column, that's the income. And then horizontally, you have the asset. Green, full waiver, and then yellow, partial waiver. For a one-person household, instead of upon the reform, you can go to the right-hand side. That is, you will get a full waiver when you earn $7,575 instead of just $5,300. And there will be a partial waiver. There will be full waiver for those earning between $5,050 and $7,505, and then for those earning between $15,150 and $7,575, there will partial waiver instead of limiting it at $7,950. And then for the asset limit, it will be expanded by 6 times. And in fact, if you compare the two diagrams, it is clear that for the yellow part, and even which stands for partial waiver, as well as the green part, which stands for full waiver, you see a huge enhancement. And then let me take an example of a 3P household. Instead of $19,750 that qualifies for a full waiver, in fact, you still get a waiver when you earn $29,625. That is earning between $19,750 and $29,625. Instead of just partial, you have a full waiver. And then for those earning between $29,625 and $39,500, instead of not having any waiver, you'll have partial waiver. And then for the asset limit, it will be expanded by 3 times, so that it will be $514,000 instead of just $127,500. So you will get where can we get the diagram? On the 25th of March at our press conference, we made use of this diagram to illustrate our point. We've issued it to you and it is available online. Sorry, speaker is off mic. We have the information in our paper. Well, which page and which part? Sorry, the member is off mic. Sorry, the member is off mic. Bureau. On the 25th of March, we had a press conference and we made use of a PowerPoint to present our points. I hope members will pay attention to the presentation. If you can't see it, it doesn't matter. I will just continue with the principles involved. That is why we believe that there is a significant enhancement. In the past, people might qualify for the income limit, but not so in the case of asset. Today or in future, they will be entitled to partial or even full waiver, so that the low-income grassroots sector will benefit from the reform. In other words, as a result of increases elsewhere, they will have a reduction or even exemption. That is, instead of having to pay, they may now qualify for full waiver. Secretary, I think members would like to have a clearer idea for the asset limits. Please tell us exactly what the new limits are like. For the asset limit, it will be increased by 3 times, 1,207,500 to 514,000, which is the same as that for applicants for public rental housing. As I have said in the past, people might qualify in terms of income limits, but not so for asset limits. In the future, instead of not having waivers, they will be entitled to partial or even full waivers. That's why we're saying that for the low-income grassroots, upon reform of our system, they will have a reduction instead of increase or even exemption. You can see that in accordance with the changes to the income limits and the asset limits, we are able to enhance the healthcare protection so that instead of just benefiting 300,000 people, 1.4 million people will benefit. In other words, an extra 1.1 million grassroots members of the public will qualify for full or partial waiver. In addition, we have already got 630,000 people who already benefit. In other words, we have got 2 million people in the vulnerable group sector or the grassroots sector who will have full or partial health care protection. Members don't have this. This is good. I bring this with me because I don't expect you to read it now. In fact, the announcement was made on the 25th of March. Information was released on that day, and we made use of PPT to illustrate a point. A lot of information has been issued. Today, I want to make use of this opportunity to show you that we are enhancing the safety net, and you will focus on this point so that not just the electrical will understand it, but then the entire population will understand the proposals. And then would like to enhance the safety net. If you don't belong to the 2 million low-income group, well, in fact, in the future, there will be a non-means tested annual cap of $10,000. That's the second tier of the safety net. So that in the unfortunate case that you suffer from chronic or serious illness, you won't become the medically vulnerable and you will be protected. And everybody among the 7 million population can benefit in case they are in need. So it is like a medical insurance from the government for the people. And thirdly, there will be more innovative drugs as well as medical devices. We are going to expedite the introduction, approval, and registration of such drugs and medical devices so that more people, in particular the middle-income families, can benefit from the subsidies given to the drugs as well as the medical devices. And then enhancing the safety net will benefit the entire society. The hospital authority will announce the final details of the fees and charges reform. There will be more sort of a briefing so that we can introduce the reform next year. So this can benefit everybody. So the first and foremost principle is that there will be no lessening of the commitment. All the gains will be plowed back into the public healthcare sector so that our safety net will be thicker, denser, and better, and nobody will be denied appropriate treatment as a result of lack of means. Well, for this reform of the fees and charges, it is part of the overall public healthcare reform. As President Xi has said, reform is always there, and it is not a smooth, wide path. Well, we have to be firm in walking along this route of reform. Thank you. Thank you, Secretary. 8 members have pressed the button to request to speak. We might have time for a second round, but first of all, 4 minutes each. First of all, Ms. Jovi Chen.
Thank you, Chairman. Well, we have a high public healthcare subsidization rate in Hong Kong. In the long run, it's not sustainable. There is a need for reform. But local residents and patient groups have also voiced their concerns. I hope the government will take their heed. For example, there is a problem with insufficient or uneven distribution of consultation services at night, and there are also many housing estates with elderly residents without the support of clinics. Now, for the annual annual fee cap of $10,000 is easy to understand. It helps those who are seriously ill, and the cancer patient groups welcome this initiative. But the secretary also spent a lot of time in explaining the rest of the paper, and that's the medical fee waiver mechanism. Now, this mechanism is so complex. It seeks to alleviate the financial burden of the grassroots, but then it's so cumbersome, and there are different formulae under this mechanism. Members of the public are concerned about the application procedures and the burden on them. For example, will there be streamlined processing, such as the use of I'm Smart for the sharing of data with the social welfare department? And members of the public are very concerned as to whether they are eligible for partial or full fee waiver. Now, this paper was floated 2 weeks ago, and we were consulted. Now, from now until gazettal of this arrangement, Secretary, will there be room to further adjust the arrangement? Secretary, this is a comprehensive reform, and in particular, for one of the 3 pillars, we want to enhance the safety net. Members of the public may not be aware of this new initiative. They may not understand that they are now covered by this safety net. As mentioned just now, with the new mechanism, the number of citizens eligible will go up from 300,000 to 1.4. Members of the public may be interested to find out if they're eligible for medical fee waiver, and that is why we will commence the operation of this. This mechanism will commence operation on the 1st of January next year, so that there is time for us to explain the nitty-gritty and for us to draw up the specific details of the plan. I will give the floor to Dr. Tony Ko to explain more about the application procedures and measures to help needy citizens in applying for the waiver. But let me first take the last question. We promulgated the proposal on the 25th of March, and since then we have heard views from different sectors, and this is just reasonable. As it is a major reform, we need to gauge the views of different sectors, and we do attach importance to these views. Then we'll also step up our efforts in explaining the policy to, say, different patients groups and the local community. I need to stress that this is a comprehensive reform, and the fees and charges at different tiers are intertwined. We will consider the matter comprehensively before finalizing the details. But we remain steadfast in relation to the directions of reform. I'll give the floor to Dr. Tony Ko. Thank you, Secretary. We've been talking to patient groups, the local community, and other stakeholders to explain to them and listen to their concern about the proposals. Now, specifically on application for the medical fee waiver mechanism, we have substantially streamlined the procedures and relaxed certain criteria. First, on the definition of household, we've adopted a narrower definition. That it means the applicant will need to provide particulars relating to himself instead of the information of the whole family. So that's a kind of streamlining. In terms of time frame, in the past we usually spent 12 months. Now it will be extended to 18 months. Now, for recurrent application, there is no need to submit the income and asset situation information again, because from our experience, for chronically ill patients, usually the family circumstances will remain the same. So confirmation is all it takes to submit a recurrent application. As for eligibility, now there are different government departments which have different schemes, and some citizens have already submitted information and they have got approval from different government departments, so there is no need to conduct the assessments afresh. More importantly, we will upgrade our computer systems. We will accept e-applications. Now, in fact, nowadays, if you apply for funding under the Samaritan Fund for expensive drugs, you can make use of an app to make applications, and you can check your eligibility through the app, and that saves time. We will also roll out something similar for the medical fee waiver mechanism. Citizens will be able to check the eligibility application status through this app. Our internal computer system will also be upgraded for the purpose of streamlining procedure. Next, Professor Chairman Kong. Thank you, Chair. I have the following questions relating to public healthcare fees and charges reform. The first point is to encourage members of the public to optimize the use of medical resources and reduce wastage. That's the purpose of this reform. So after introducing this reform on fees and charges, what do you seek to achieve in terms of avoiding misuse and encouraging reasonable use of, for example, A&E resources? The second point is that after introducing the reform, the overall subsidization rate will remain at about 90% for the public health care. I want to know whether the 90% figure is a long-term or short-term goal. If it's a short-term goal, then what is the ultimate goal for the Bureau in order to ensure sustainability and quality of the public healthcare system? The other point is that after introducing the reform, the fees and charges will see a hike. For example, for GOPC, the fee will go up from 50 to 150%, up by 2 times. As for SOPC, for first appointment, the figure will also go up from $135 to $250. So that's again a substantial increase. What has the government considered in proposing the new levels of fees and charges? And for the middle class, which will not be covered by the medical fee waiver mechanism, etc., how do you make sure that their choices will not be compromised because of lack of means? Secretary. The goal of reform is to introduce a 5-year plan taking a gradual and orderly approach. We will adjust the subsidization rate and achieve the 80 to 90% rate. So that's our KPI. The KPI for reducing wastage and misuse is this. By raising the A&E fees, we seek to reduce misuse by 5%. This is just a baseline, however. In 5 years' time, we will further evaluate the long-term goal. We're not going to set a long-term goal as we're taking the first steps. At an appropriate juncture, we will review the fee levels 2 years down the road, for example, and then we will further consider the long-term goal of the 90% subsidization rate in 5 years. I will not say that the 90% rate is the ultimate goal, because we need to sustain our efforts in taking forward the reform. So after achieving a 90% subsidization rate in 5 years' time, we need to consider the overall healthcare reform, including medical healthcare financing, the voluntary health insurance scheme, etc. So the upcoming review will not be just about the fees and charges in public healthcare, but also the sustainability of the public healthcare system, including financing. Now, the member has urged us to consider the fee hike, and I emphasize that it's not reasonable to just consider the user's perspective, because at the moment the subsidization rate stands at 97.6%. It is far from reasonable. We propose to lower it to 92%, and we also have a medical fee waiver mechanism, so the rate of increase will not be forecast in such a manner, and that is why we have different schemes in place to help different patients. For inpatients with more complex situations, we may allow for a higher subsidy rate. For outpatient straightforward cases, the rate may be lower. Ms. Connie Lam, I have questions about the public healthcare fees and charges reform. The government has proposed to raise fees and charges for A&E services in order to ward off abuse, say for the semi-urgent or non-urgent patients. We should discourage them from using A&E, but at the same time there should be more slots for GOPC on public holidays and at night. Now, so the Secretary mentioned that in fact the night consultation slots are not fully utilized, but if you raise the fee to $400 in the future, you will see a surge of utilization of GOPC services, especially at night and on holidays. So you need to expect the surge coming from patients that currently do not use GOPC. So you need to improve the online queuing system. The second point is about the safety net. At the moment, 300,000 patients benefit from the safety net. In the future, a wider net will be cast to cover 1.4 million patients. Secretary has mentioned measures to streamline the workflow and shorten the time for vetting applications. Now, there is already a lot on the plate of medical social workers. How do you ensure that 1.4 million patients will benefit from a wider safety net in the future without compromising the work of the medical social workers, because they already have a very heavy workload? Many patients will be applying for medical fee waiver mechanism, and that there may be a need to provide extra funding. The third point is this: for psychiatric day services and also community psychiatric nurse service, they will remain free of charge. Is it because patients do not have other alternatives for these services, so they come for free? And can you also explain why aren't you waiving the fees for inpatient services as well? Well, the last question is this: for OALA, you are exempting elderly people above the age of 70. The Social Welfare Department vets applications from elderly people above the age of 65, and they are eligible for this safety net protection as well. So through this network, will you consider adopting the assessment already done by, say, the Social Welfare Department and the Housing Department, so that medical social workers will not need to take up extra work?
Well, evening sessions. When we launched the primary healthcare service, we did emphasize that the first point of contact should be family doctor. When you fall ill, we should have the idea of family doctor for all. Now, in fact, for us, the evening sessions indeed play the role of family doctor. For the majority of the citizens, if they can afford it, I think they have the service of a family doctor in the private sector. In fact, the private sector is much larger than that of the public sector. For the general outpatient clinics, we have got 5 million or so sessions. But then the private sector, the capacity is up to 20, 30 million. Well, in fact, the fees and charges will be a driving force. We will make sure that the A&E fees will be higher than that for the general outpatient clinics. If not, then if the A&E doors are always open, then there will be abuse and misuses. The A&E is convenient, but it doesn't mean that we should allow their resources to be wasted and for acute patients to be affected. For enhancing the quota for evening services, for quite a period of time, the hospital authority as well as the private sector have been enhancing the evening sessions. Say, for example, during long weekends, 23 public clinics provide evening service, 14 more will join, and in fact 18 in the coming Easter will provide service during the public holidays. But of course, it is important to steer the demand. Let me sort of look at the case of a Cat 5 patient, that is a patient with milder conditions. A patient may not know the category that he or she falls into. We can't assume that they know from the outset. If somebody is feeling unwell and if he thinks that he's having something serious like a heart disease or a stroke, or if you encounter an accident, then of course, without thinking much, you will go to the A&E. But then for milder conditions like a leg pain or finger pain, would you like to be attended to immediately, or would you like to book an appointment either in the public sector or the private sector? Well, if the judgment at that time convinces him that it is an A&E case, we won't stop him from visiting the A&E. But after being triaged, and if he's found to be in Cat 5, then he should consider whether he should continue to wait at the A&E department or whether he should identify other alternatives. Now, Dr. Koh will explain more about the safety net. That is the role to be played by our medical social worker at the hospitals. I want to say that instead of 300,000 being eligible, there will be 1.4 million. We are not saying that all of them are patients, so please don't call them patients. 1.4 million citizens will be qualified to apply. The majority of them are healthy, and we hope that they will stay healthy. According to the current statistics, every year we have got 14,000 applicants asking for and granted for waiver. So on the basis of 1.4 million, we believe that 66,000 would need to apply for a waiver. In the case of psychiatric service, for day psychiatric service, the fees will be waived. They are very different from inpatients, because we haven't got any sort of likelihood of abuse or misuse. I don't think you will, for no reason at all, visit the day psychiatric service. On the other hand, we hope that as a result of the psychiatric conditions, a patient may become vulnerable, and we encourage them to use our service. We hope we can provide better support to encourage the psychiatric patients to visit our day centers. You refer to the elderly aged 65 or above and who are receiving OALA. Well, we have the income test, we have the asset test, and so the case is a bit different. But then if somebody is already getting the OALA, so he has got the experience of walking through the screening process, and I'm sure we have already got information about his income as well as his assets. So I believe that we can easily make use of the existing information to deal with the application. Dr. Koh can also explain about the details. Well, in the interest of time, probably you have to reserve your reply for later time. Members, if you want to get a full reply from the Bureau, make sure that you leave behind sufficient time for the replies. Next, Mr. Kingsley Wong. Well, the reform is going to affect everybody. Well, you may say that 1.4 million will qualify for the waiver. There are 3 categories of recipients who are exempted, but then there are about 600,000 of them. What about the rest? There is 800,000. How can those 800,000 citizens know that they qualify for the waiver? And can we sort of say that among the OALA recipients, they will qualify because there are 9 different categories? Can we say that for, say, the recipients of the Working Family Living Allowance, they will qualify for the waiver? Can you sort of give us an idea if somebody is already receiving the benefit, he or she will get the waiver either fully or partially? Just now the Secretary talked about a lot of details. Can you not have a comparison table so that everybody can tell whether he or she is going to benefit from the reform? And make sure that you spend less but you can achieve more. Now you are enhancing the fees for the A&E department. Can you not subsidize the NGOs to provide outpatient service right next door to a hospital, right next door to an A&E? During holidays and the evening, we don't have adequate access to outpatient clinics. When you are having dizziness or when you have a fever, you are not sure how serious you are. So why don't you subsidize NGOs to run clinics to divert the patients from the A&E departments, especially if they can be located right next door to the hospital? Secretary, and what about the GBA? Can you subsidize body examination at the GBAs while patients are waiting for their surgeries to be carried out? They would like to be given body checks, and if you can have mutual recognition of the outcomes of the body checks, then I'm sure you can save money in terms of the money spent on surgeries. For those who are entitled to full waivers, I think the mechanism is clear. Now what we want to look at, what we want to fine-tune or enhance will be those who have to go through the income test or asset test. You may say that it's complicated, but in fact there are just 2 components, your income level as well as your asset level. But then we have got different number of members in different households. The household size is different, so we have got a different figure for different households. We have 1P household, 2P household, 3P households. But then for an individual, you only have to look at one particular set of figures. You have to look at the limits. Well, in fact, the information is readily available via different channels. I would suggest that individual citizens who are interested in this topic can just look at the relevant category of household instead of just looking up all the information. In this way, you will be clear about the information. For those who can afford should pay, and you say that there should be acute clinics right next door to an A&E department, there are disadvantages. If we are to provide such facilities, then more people will flock to the A&E department before they visit such a clinic next door. I don't think we are going to house them right next door, even if we are to do so. Now, in the past, the Medical Association encouraged doctors to provide such service in the evening near to hospitals. But then if we can't drive or change the behavior of patients by adjusting the fees, it just won't work, and it didn't work. For GBA, body examination, well, we will look at the quality of the check received by the patient. Let's not just focus on the GBA. A patient might have been examined elsewhere, and our colleagues will make a professional judgment to check whether the outcome of the examination is acceptable and form the basis for his treatment and management. But then if you say that if we make it formal, that is, we refer the patients to the GBA and make them undergo the checks in the GBA, then I think there may be a problem, because how the reports are to be transferred back to Hong Kong, and in fact they are written in simplified Chinese. We do have colleagues who can read Chinese, but then such reports are not adopting a standard format. We have yet to check how the reports can be used in Hong Kong directly. Thank you, Secretary. Next, Mr. Yang. I'm grateful to Dr. Koh as well as the Deputy Secretary. I had an appointment with you twice to express my views. Well, every day residents tell me that they are really concerned. Well, in fact, many elderly people were talking to me all the time about the fees and charges. They are not clear about the actual details. Well, many colleagues have said perhaps we should simplify the mechanism to facilitate public understanding. Secretary, I think you need to look at this seriously. Mr. Kingsley Wong talked about recipients of OALA, recipients of book and study expenses. I think their income and asset, as well as recipients of working family allowance, well, I think their income and asset limits are rather similar to this. But then for OALA to be received by somebody who is 65 or who is not yet 65, I think you can make use of that dividing line to illustrate your point. Not everybody is as smart as you. We may not be able to understand the information so readily. Well, if you say that anybody who's receiving OALA will be exempted, will qualify the waiver, then you can put the mind of many people at ease. And then you said that only 60,000 people out of the 1 million who qualify will apply. I think you are underestimating the condition. Now, if I have to apply, if I am among the 1.4 million, then everybody will flock to apply. And you've just got a handful of medical social workers. How are you going to handle the huge number of applications? I'm sure you have to adopt the principle of streamlining before you can get it done. Take Kowloon City as an example. If a child is unwell at night, either you go to the QE's, A&E, or you go to St. Teresa's Hospital. You may say that we should go after our family doctor, but where are we going to find our family doctor? Is it so much that we don't want to visit our own doctor? I think you better have more evening clinics so as to divert the patients from the A&E departments. It is something that we should think about. Not everybody would like to visit the A&E department. Somebody may not have accessibility to, say, St. Teresa's Hospital in Kowloon City. You better wind up. Well, when you look at the fees for drugs, can you not make it simpler? when I have a cold and flu, if I go to a public outpatient clinic, you have got many drugs being administered. If the drugs are charged one by one, item by item, then it will be a very complicated issue. Now, in the case of fever, you may have 5 or 6 different types of drugs. I think you better charge $20 instead of the current amount. Better give us a clear idea. Otherwise, nobody can tell how much I have to get ready when I go to a hospital, $500 or $1,000. And I just wonder whether, in turn, you are going to drive up the fees charged by the private clinics.
Just very briefly, Secretary. Well, it's hard for me to be brief. He asked 4 questions. So the first question is on whether this will jack up fees and charges in the private sector. Well, we have 20 million for the private clinics in Hong Kong, and for the A&E, we have some 1.5 million. And the majority of patients in the A&E are Cat 4 or 5 patients. They're semi-patient or non-patient. If we're able to reduce that proportion to, say, 1 million, this will help alleviate the pressure on public health care. We have 20 million attendances in the private sector, and comparing to 5 million attendances in the GOPC, that's really a small number. We don't envisage fees in the private sector going up as a result. As for medication, well, I want to clarify this situation. For common cold or flu, there shouldn't be a long prescription list. Doctors will have regard to the symptoms of patients presented in writing prescriptions. When it comes to medication, it's not about drug expenses. It also involves the services provided by our administrative and professional staff. Now, using your example, I'd like to illustrate that if a child suffers from fever at night, we're not saying that the parents must not bring the child to the A&E department. We understand the parents' concern, and if the child is taken to the A&E department, he will be triaged. Some children below the age of 18 may be triaged to Cat 3. We understand parents' concern. If they want to bring their child to the A&E at night for high fever, then for patients of Cat 5, they suffer from very mild conditions, and they may cram the queue such that Cat 3 patients cannot receive care within 30 minutes. And this is exactly what we want to tackle through the reform. As for applications, usually the applications will not reach medical social workers directly. The application forms will first be dealt with by our administrative staff. They will go through the relevant documents such as income proof, asset proof, only for applications not relating to the means test will a medical social worker be involved. I'll give the floor to Dr. Cole to supplement. We understand the public's concern about the medical fee waiver mechanism. Now, there is a need to consider the patient's conditions as well as the financial situation of the patient, and also whether it's a communicable disease. To answer very shortly on the question of vetting applications, we have a very straightforward mechanism to check if the patient is eligible. It should be done quite quickly. Ms. Chan Ho Yan, Well, since the administration floated the proposal, we've received a lot of inquiries from members of the public. So, in view of the strong public views, I'd like to invite the administration to give us written replies. I want to emphasize that over the years, we want to take forward the healthcare reform. We want to come up with the best effective way for, say, medical financing, etc. However, this reform involves substantial raise in fees and charges, and there are strong repercussions, and we represent the people. I'd like to bring their voice in now. First, in relation to public healthcare fees and charges reform, according to the administration, this is a comprehensive reform, and I fully agree with that. It is a very controversial, large-scale reform. Has sufficient consultation been conducted? At the moment, we have other supporting facilities which are lacking, such as community pharmacies and insufficient GOPC slots, insufficient evening slots, and inadequate primary healthcare services. And the government is hastily introducing this fee hike starting the 1st of January 2026. How are we going to level with the public? The reason why it is not easy for them to understand. You mentioned that the number of eligible and beneficiaries will increase from 300,000 to 1.4 million. The Bureau emphasizes that if you are sick, you should have access to medical services. We should consider, with the additional resources, how we can help people quicker. But the number of applications is envisaged to go up from 300,000 to 1.4 million. How much of this provision will go to administrative fees? Are you going to hire more social workers or nurses, doctors? The third point is this. When it comes to episodic diseases, I don't think patients would want to abuse the system. There should be more tools for the administration to tackle the problem. In the 2019-2020 financial year, the Legislative Council approved funding of $10 billion for a stabilization fund to be set up in a public healthcare sector. In the event of any financial problems, the stabilization fund can fulfill its function in order to achieve the subsidization rate of 97%. And that's the purpose of the fund approved in 2019-2020. It's a $10 billion fund. Have you considered making use of this fund first and not to act so hastily? Finally, according to the administration, we should consider different perspectives. Don't just consider the fee hike and consider it unreasonable. But from patients' perspective, of course, it's unreasonable. The fee will go up from $180 to $400 for the GOPC alone, and also for SOPC, the fees will also go up. Now, for bone fracture, or minor fractures requiring casts to be put on the patient, at the ANE, they will be classified as Category 3, and that means they will still be able to. They will still need to pay $400, and from the professional's perspective, it is not reasonable. They are required to visit the ANE clinics. So, a quick written reply to my question, please. For the $10 billion stabilization fund, will the government consider first using this fund before pushing through the fee hike? Secretary, I want to emphasize that since the member kept referring to the reform as a fee hike, it's not just a fee hike, it's a comprehensive reform. We need to consider with increased fees at the ANE, how many members of the public will be eligible for extra protection. We also introduce an annual fee cap, as well as other forms of subsidy for, say, drugs. I want to emphasize that for 2 million citizens in Hong Kong, they are the grassroots, and indeed for those with means, they should shoulder part of the responsibility through this co-payment model. We need to introduce a reform in order to help those in need in a more precise manner. And as I mentioned, it's not a one-off reform. We will conduct reforms in a gradual and orderly manner. We have a 5-year plan. At this moment, the goal is very clear. We will lower the subsidization rate to 90% for the first stage. It will be done in a gradual and orderly manner. As for the $10 billion fund you mentioned, $10 billion account for just 10% of total healthcare spending in Hong Kong per year. Even if we utilize the fund, it will not be sufficient in tackling the fundamental problems. We won't be able to achieve what we want to achieve. Say for patient of Cat 3 suffering from bone fracture, you call $400 fee reasonable. Now, I want to make one thing clear. For a patient suffering from bone fracture, the treatments include casting, surgery, and consultation. The cost of these services would go far beyond $2,000, far exceeding the A&E charges. So $400 is really value for money. It is exactly for this reason that we are not able to achieve the target of treating Cat 3 patients within 30%, or at least 90% of them will receive treatment within this time frame. And that is why we need to introduce this reform to rationalize the use of resources. I'm not asking the Secretary to use the $10 billion fund. I'm asking him to use this $10 billion as a start so that you don't need to push through the fee hike so hastily. I think he's noted your comment. Next, Mr. Peter Show. Well, I didn't read very carefully about the proposed fee and charges reform, but for A&E department, the fees will go up from $180 to $400. My take is this. Well, I was talking to a member of the public in a public event, and I was told by this aggrieved citizen that he waited for 8 hours at the A&E department the previous night because the daughter was suffering from high fever and flu, and then other citizens asked her why didn't she go to a private doctor instead. Now I can give you another example. A friend of mine fell tripped over in the street about 6 months ago. My friend suffered from bone fracture at the arm like that. At the A&E department, my friend waited for 4 hours. No treatment was provided. In the end, my friend went to a private hospital, and in the end, my friend paid $100,000 for a surgery. What I wish to convey is that if you have an emergency, do go to the A&E department for help. For other circumstances, you should make use of other avenues available. Now, I think that the $400 new fee is not high enough, because if you go to a private clinic, you're charged at least $400, $500 at night. So if you have a stomach pain, flu or other ailments, fever, then you may still crash at the A&E first. Now, if the fee hike is substantial enough, then a patient may rethink whether it's worthwhile to visit the A&E department. So I think that the increased fee to $400 may not help you achieve the effect. We need to rethink the function of the A&E department, which is to save lives in emergencies. But at the same time, I share the concerns of members there should be more choices available, such as evening clinics. Many people do not prefer private hospitals because it may cost a lot more if the doctor advises the patient to stay overnight, for example. So there is a huge cost behind. And there may be, if you go to another clinic, and they may ask you to join the public queue. So you need to step up capacity for evening slots. Now, Secretary, you just now said that the value of the reform far exceeds that of the fee hike of $400. Now, I agree with you, because if the fee hike goes beyond just $400, you will encourage members of the public to rethink whether to go to the A&E department. I'm not against a $400 proposal, but perhaps you can rethink your position.
Just a brief note. I thank you for your views. $400 would not be the final figure. We hope that in 5 years' time we can reach our target set for stage 1. If you do not object, I would like to extend the meeting time by 15 minutes. Thank you. Next, Mr. Michael Tian. Thank you, Chair. 2 questions for you, Secretary. Let me share 2 scenarios with you. No pressure at all. For we Chinese, we say that we don't fear that we have got our name wrong. We don't fear that we have got a wrong fate, but then we are worried that our name is not right. Now, there are different ways to describe your reform, and so the general public may have a misunderstanding and they have dissatisfaction. Many people have been talking to me endlessly, and I think it's better for you, Secretary, to face the public and clarify the position and make changes if necessary. For us, we know that for the drugs, each item $5, at most 4 weeks. And then for the specialties, $20 for each type of drug and 4 weeks at most. So the information is brief. Well, Chair, you and I are DBS alumni. We aren't too proficient about the Chinese language. Well, for 4 weeks most, to us, we think that it means that we will be refilling the prescription 4 weeks later. I think it's better if you say that per drug and per week. And then you can easily come to know how much you have to pay. Many people have preconceived ideas. Well, citizens would only remember a soundbite, so it is worse if you have got the name incorrect. Don't talk about maximum 4 weeks. Just talk about per drug per week. And then you have got the triage system. You have got critical as well as emergency in English and 危殆危急 in Chinese. And then another 3 categories: urgent, 緊急, semi-urgent, and non-urgent. Well, you have an A&E, and then you have got non-urgent cases. So non-urgent cases should not be attended to in an A&E department, and they should have visited a general outpatient clinic. So $150, why are you attracting such patients and you are charging them the same? So I said that there are international definitions for urgent, semi-urgent, and non-urgent. I think it's a matter of being bound by the international concepts, and it is merely a Chinese translation. Well, there are views saying that instead of $180, it should go up to $300. They could have visited the general outpatient clinics. They should be charged $500. Well, I think you should impose a $300 fee on those who qualify for the A&E, and for those who shouldn't have visited the A&E, they should be slapped with a rate of $500. Mr. Chen, you're right. We need to be clearer about our explanation. Well, for the drug fees, we talk about the amount of money that you need to spend per drug instead of the maximum period of time that you can get your drug for. Yes, there has been some misunderstanding, and I'm afraid that there are rumors and it's a matter of scaremongering. I think we need the wise men to help to stop the spread of the rumor. Dr. Cole and myself, through different channels in different media, explain the matter to the public. They don't have to go back to get the drugs again in 4 weeks' time. It is on the 25th of March, we had a press conference, and there were people who were writing stories on this point. Let me say this once again. For per 4 weeks, it is a matter of the amount of money you need to pay. If you need more than 4 weeks, you can get them for up to 24 weeks and pay for that. Well, I agree with you. For the non-urgent cases, the majority of them don't need to visit the A&E. But then you need to think from the perspective of the citizens. Some may not know, but others may know, and yet they would choose convenience over other considerations. Well, when they come, we'll have a triage, and each patient will be told the category that they have been triaged, and then the citizen can decide whether they would like to stay or whether they would go for other alternatives. For our fees and charges, we believe that there should be consistency across the board. For frontline staff members, if they triage the patients and then charge accordingly, then there will be conflicts and confrontations. So we want to look at the costs, and therefore we calculate the right level of fees, $400. In fact, we're supposed to have $400 for all 5 categories, but then A&E departments are A&E departments. It will be difficult to collect the fees because the patient may need to be given resuscitation upon arrival. So we say that for the first 2 categories, they would be exempted. Well, for the other 3 categories, well, for the A&E fees, could only make good a very small ratio of the total cost. Well, the secretary said that differentiation in fees will cause confusion. Well, I sell clothes. I know where I can make it cheaper. But then if the consumer doesn't like it, then it is useless. Well, what happens is that it's better if you charge me $500 and the others $300. Why should you make it consistent and $400? Now, they think that by having a triage and there are 3 categories, then there should be 3 different rates. Time is up, so I won't ask for further replies. Next, Dr. Dennis Lam. Thank you, Chair. First of all, for the medical or the healthcare reform, I think today we have 97% as the subsidization rate. In 5 years' time, we would like to lower it to 90%. I think it means a lot to make our system sustainable. With an aging population and the healthcare cost is going up, both for drugs as well as the medical devices. We need to balance our consideration with affordability. I have to praise the Secretary for his vision. Well, in fact, in industrial development is now at Industry 4.0. We want to lower the health costs. We hope that the public healthcare sector can be enhanced, and we need to be smart in delivering our service. Now, the Secretary talked about using the HA-Go system to carry out the means testing, the income testing. Can we not have AI to screen so as to lower or reduce the workload of the medical social workers? What about smart healthcare? What is the state of play and what is your plan? Smart healthcare, that is, or health tech. Well, in fact, it has always been our vision. Let me defer to Dr. Cole to tell you more about that. Dr. Cole. Well, everybody is right. When it comes to smart healthcare, the hospital authority has done a lot. As Dr. Lam has said, for our administrative work, we do have such an element. Not too long ago, we said that we relied on AI to write our medical reports. As to the point made by Dr. Lam, we did consider that. Now, for the income tests, it will be easy and simple. And in fact, certain procedures can be carried out by computers. We don't need complicated AI. And then, on the other hand, we have got AI to help us in, say, for example, clinical work, helping doctors to make clinical decisions and getting information needed. In Hong Kong, what is good is that we have got the HA teams to help the doctors, and we have got big data, and we have got the connection of different systems. Our appointment system, our fee collection systems are all interrelated, and we can rely on AI to help with the screening. And then when patients want to make an appointment with our GOPC or the SOPC, I think our AI system can help us to prioritize the bookings. So this is in line with what Dr. Lam is advocating. Next, Mr. Tang Ka-Piu. A few points to make. First of all, for the medical fees and charges reform, not everybody will agree with you. Many people are worried. So technically speaking, I just want to know how you can properly launch it in 2026. It's best if you can listen to more people and try to fine-tune your package. Here I come up with two proposals for the consideration of the Bureau. Well, when you first launched the proposals, when I was interviewed, I already made this point. That is how you can make sure that those who are eligible for partial as well as full waivers, how you can process all the applications. In fact, we have got the HA-Go, and I think the government can easily make use of the HA-Go to collect the information and have the information processed at the back office. But probably you won't have sufficient time to do so. Can you not advance the timetable, that is in August or September, you start to receive the applications, though it will come into effect in January next year, so that there will be more time for your staff, and we can also extend the publicity campaign. Citizens won't take it seriously unless and until you start to receive applications. If you have advanced applications, then people will start to learn whether they are eligible. And then at the district level, we'll also be helping you to publicize the message. Another point is about the relationship between evening clinics as well as the A&E departments. It is indeed a headache. Patients won't like to visit the A&E department in the small hours. It is only when they feel unwell, only when they think that it's a matter of life and death, then they will go to A&E. Nobody would like to walk in the A&E department. So we need to know about what is supposed to be regarded as non-urgent, and then you can wait till it is dawn, and then you visit a clinic. And we can also reduce the number of conflicts. Can you not encourage more remote consultation in the private sector, say post 9 p.m. up to 6 a.m. the following morning? Can you not get hold of doctors and medical organizations to provide remote consultation during those hours, so as to put the mind at ease, and then doctors can give advice to the patients? Some organizations are doing this, but I think it has to be enhanced, and it can help with diverting the patients.
Secretary, thank you for your comment. When it comes to implementation detail, application, and other details, we're happy to seek further views. We have until the implementation date, that is the 1st of January next year, and we will, of course, further streamline the procedures. Dr. Tony Ko and his team have been working on this. About A&E department and evening clinics, I want to emphasize that every individual is responsible for their own health. So when one feels sick, then one must first assess whether there is a need to go to the A&E department or a nighttime clinic. Sometimes you may not need urgent care. If it has to do with, say, some localized pain on the finger or the foot, then that's relatively mild. Now, but for, say, bump in the head, the bone fracture, then the things are clearer. We're not turning away each and every patient, but we want to improve the services. We want to enhance support for stroke patient or heart disease patient. That is why we cannot set fees at a excessively low level, because especially during holidays there are still long queues for the A&E services. So we need to address the situation. Now, engaging other professionals, well, it will become costly. Patients may not need to spend extra in transport, but that's different for doctors. We also need to ensure data security, and if you are to provide services in the middle of the night, I believe this will further drive up costs. We need allied health professionals and other professionals to stand by in order to operate the machines and equipment for telehealth services. We don't think this is the most cost-effective option. Still, we will continue to review the situation and enhance primary health care, especially for evening healthcare services. But this goes hand in hand with other prongs of the healthcare reform, such as the public healthcare fees and charges, etc. Mr. Edward Lau, I thank the Secretary for explaining to us that, in fact, the safety net now covers 2 million patients. They enjoy, say, the annual fee cap or the medical fee waiver mechanism. We've had grievances in the community, but upon careful scrutiny of the plan, we find that these people are actually covered by the safety net. So I thank the Secretary for his explanation. Now, according to our recent survey, people feel quite strongly about the rise in fees at the E&E department from $80 to $250. And then when we ask further some of the respondents' views, we're told that, for example, elderly patients wait 6 months for a follow-up appointment, and then the consultation process may actually last for half a minute. The major difference is that if a long subscription list is made out, then apart from paying for the $250 consultation fee, the fees for drugs may go up to $1,000, and that's several $1,000s for SOPC services. That's a huge burden on our elderly patients. Is there room to provide further waiver exemption for the elderly population? Can we take a phased approach? For example, for SOPC appointments, can we introduce a smaller rate of increase, not from $200 to $1,000, but a smaller rate for our elderly patients? Secretary, first of all, if an elderly patient pays over $1,000 for a trip at the SOPC, then definitely this patient requires a lot of medication to treat the chronic diseases. Now, as I said at the outset, we have 600,000 patients already covered by the waiver mechanism, together with a 1.4 million in safety net, altogether 2 million. And actually, we have some 2 million out of the 7.5 million people in Hong Kong covered by the safety net. As for SOPC fees and charges, I'd say that the impact brought about by the proposal will not be significant. We need to introduce the fees and charges reform because we want to achieve this purpose. According to our data, many patients at the SOPC can be dealt with by our doctors at a family medicine discipline. So they can be downgraded because they are in a stable condition. The first appointment of a patient will involve the family doctor at the primary healthcare level. If need be, the case can be uploaded to an SOPC, and once the condition stabilizes, the patient should be downloaded to a family medicine or GOPC. If we don't have this two-way mechanism, then the whole mechanism will be skewed. It will be a reverse triangle, and that means a waste of resources. It is a waste of resources for a specialist to treat minor or mild diseases, and that's one of the objectives of our reform. We need to avoid wastage. Now, you talked about a patient seeing a doctor for just 2 or 3 minutes. The patient may find this situation unreasonable, but at the SOPC we do have colleagues spending a lot of time to consider complex situations. So we should allow time for SOPC doctors to treat these cases. For minor conditions, they should go back to the family doctors and SOPCs. Ms. Judy Chan, I want to say at the outset that I support the reform. There is imbalance in our healthcare system and also mismatch of resources. I have high hopes for this reform. I hope that this reform can address these problems. Other members already touched on this issue. I strongly support this view, and that is whether it is possible to streamline the application process. In particular, the eligibility criteria vetting. Even as members of this council, it has taken me time to go through this document. Please make your plan more accessible for the public. My second point is this. The Secretary mentioned 2 million eligible beneficiaries. Many of them are already applicants for schemes under the Housing Department or the Social Welfare Department. Instead of requiring applicants to submit different forms, is it possible to consolidate different mechanisms? I know that this may not happen overnight, but is it possible to allow, say, sharing of data among government departments? According to the Housing Department's new policy, tenants are required to submit declarations every 2 years. The Housing Department will then vet the application and confirm the eligibility. So although you still need to go through the application process, can you consolidate the different mechanisms to reassure the public? The second point is this. Secretary, you emphasize that this is not a fee hike, this is a reform. But from the public's perspective, they still consider that to be a fee hike. Whenever we talk about increase in fares for the public transport and for other services, we also have expectations for services to be improved. So can you give an undertaking here? We're not asking for concrete promises, performance pledges about waiting time, etc. But at least you should explain to us the merits of this reform. Say, after putting in place this reform, we should be able to shorten the queue for healthcare services by so and so. Secretary will take this answer, but I will need to further extend the meeting by a little bit because I will be the last one to speak. Thank you. First, on the point of protection, I agree with Ms. Chan. We also strive to explain our reform to the public. We strive to explain the merits of the reform. Now, members of the public consider this as a fee hike, as you put it, but I emphasize time and again that the government's commitment remains unchanged. Any additional revenue generated through this reform will be plowed back to the system to help the 3 categories of needy patients: those who are poor, who suffer from serious illness, who need urgent treatment. They have extra protection as a result of the reform. So we have enhancement and reduction. It's not just a fee hike. The objective of the 3 additional protection measures is to help more people. The safety net can now capture a wider population. As a result of the reform, some of the fee-paying patients will enjoy partial or full waiver. As for other income groups, in the past, they pay $180 for A&E services. Now they enjoy full waiver. The same goes for inpatient services. And for other essential services such as the A&E department, through introducing the fees and charges reform, we can lift pressure off our healthcare staff, and then we can save resources and manpower to focus on something more important, to protect the public, such as acute stroke and heart disease. But we have a very different treatment approach nowadays. The role of the A&E department is very vital. The A&E department should not deal with cases that involves common cold or flu, or for patients who'd like to get a medical certificate. They should focus resources to help those who are really in urgent need of care. The SWD can also tell you more about the sharing of data. Sam. Thank you, Secretary. As mentioned, we have interdepartmental collaboration. In the end of this month, the details of this reform will be gazetted, and then from the end of April to the 1st of January, which is the actual implementation date, we will work on a number of things. For example, subject to the reform, we will streamline the operational details to facilitate the public in order to drive down administrative costs. On cross-bureau interdepartmental collaboration, we have reached an understanding with the Social Welfare Department. There will be collaboration. We'll work with other bureaus such as the Housing Bureau, Education Bureau, which are also involved in checking the welfare status, eligibility status of citizens. And I also want to emphasize 2 points. Under various subsidy schemes, the government put in place various income and asset limit tests. So through collaboration, we can cross-reference the data kept by government departments, and then we can save time and resources for the vetting procedure again. And this is a way of streamlining the workflow. And if the patient is already eligible for a welfare scheme under one department, we can save resources through collaboration. We don't need to start vetting afresh. The next point is that in principle, we want to align the systems with among the different government departments, at least at the back end. For example, we have a medical fee waiver mechanism for CSSA recipients. Currently, we have this administrative arrangement. We can verify the CSSA status of the patient, and then we can grant waiver automatically. In the future, we want to step up this cross-referencing exercise by enhancing data sharing at the back end so as to facilitate the development. So that means we can support different schemes and etc. among the departments and bureaus in line with the big data trend, and this is something that we will do in the future.
I have a specific question. So come the 1st of January 2026, are you saying that the cross-referencing and interconnection would be ready? Well, for mutual recognition of the eligibility, well, we would have completed that in principle prior to 1st of January 2026. So we'll have administrative savings. And then for the exchange of data, then we will be doing that on a gradual basis. The last to speak would be myself. For SOPC, as well as the other organizations. Well, currently we have the chronic illness scheme, and we have the chronic disease co-care pilot scheme. Well, in fact, perhaps you should tell us whether you have a program to have the stable cases being referred to the private sector, taken care of by their family doctors. I know there are patients who don't like to be taken off the HA because they don't want to have their files closed. So can you tell them that it's not a matter of closing their files, but instead they are being referred back to their family doctors? Now, for a family doctor to refer a patient back to the HA, does it mean that it is a matter of queuing up afresh, or can they be able to make a booking in 4 weeks' time or 6 weeks' time? So please tell us whether someone can go back from the family doctor to the HA. And then other members have asked the following question. That is, for the fee waiver, can you apply in advance, or whether you have to wait till you have a case and then you apply for the waiver. So it's a matter of whether I can have advance approval and I can just show my eligibility upon admission to the hospital. Well, for primary healthcare development, we are developing two-way referral. It is important. As I have said, we can't have a one-way traffic in the referral system. Everybody being referred to the public healthcare system and nobody is leaving the public healthcare system. The system will just be blocked and it can't sustain, and we can't sustain it, and then the quality of the service will suffer. For the chronic disease co-care pilot scheme, we do have such a channel. That is, upon screening, if it is found that if you are suffering from high blood pressure or diabetes, if necessary, the patient can be referred to a SOPC to have a one-off check. Only a minority of patients need that. It is good. It shows that family doctors are good gatekeepers so that they can manage the patients who have been screened out. We are planning with the HA as to how we can implement the two-way referral system. For the details, I defer to Dr. Cole. That is, in future, if the Primary Healthcare Commission is to carry out the two-way referral, what will be done. It is not easy to change the habits of the patients. We can tell them that if they need it, they will be taken care of by a specialist. That's much better than everybody crowding the SOPC clinics, because it will just worsen the quality of the service, bring disadvantage to everybody. Well, the assessment for waiver will be time limited, so I don't encourage everybody to rush to get the qualification. We will make sure that there won't be a major time lag, so patients don't need to apply in advance, even before they fall ill. Dr. Cole. Just now, it has been said that for the healthcare reform, we would like to steer the habits. That's why for SOPC fees, it will be higher than other fees. For referrals, we would like to have it two-way. That is, when the condition stabilizes, then I think patients should go to primary health care or family medicine clinics. Of course, conditions may change. As the Secretary has said, we can provide, or as the Chair has suggested, we should allow for a quicker channel for patients to go back to the HA. And the HA has developed a referral system. It will become digital, so that whether you visit the private doctors or whether you visit the family medicine clinic, I think the records can be sent digitally, and we can also rely on AI to make sure that the patients can be given a consultation slot earlier. Now, for the reform that we are talking about, we're relaxing the income limit, the asset limit, as well as the household definition. The basic principles have not been changed. First of all, a patient must have the medical need first before they apply for the medical fee waiver. We do agree with the idea that you should apply in advance, irrespective of the need. We believe that the majority of the residents can benefit from the reform if they need it. In our paper, we have the 3P household example. $39,500 would be the household income. We don't want them to exhaust all their funds only because they visited a doctor in the hospital a number of times. Now, somebody may suddenly encounter economic difficulties. The MSW can grant a one-off waiver. if there is such a need. So within the same day, our colleagues can approve the application. Thank you. Thank you for your replies. Thank you, members, for your questions. Item 6 AOB, nothing under AOB. Meeting adjourned. Thank you.